and this is about treatment for physical disorder when somebody's detained under the Act. So if the criteria are met, somebody's detained under the Mental Health Act, then the question arises, what constitutes treatment for mental disorder and what constitutes treatment for physical disorder? Would it be lawful to enforce treatment of a physical side effect of psychiatric medication under the Mental Health Act? What about treating cuts or infection arising from self-harm or treating an overdose that arises in the context of mental disorder? This is something that our DMPs are very often asked, and we get asked it on our inquiries line quite often too. And we take the view that where the treatment is for mental disorder or a consequence of the patient having a mental disorder, then the treatment falls within the meaning of treatment that can be provided under the Mental Health Act. Now, obviously, if somebody has capacity to consent to treatment for physical disorder, whether or not they're detained under the Mental Health Act, that is the route you should take. Whenever you can have a capacitous consent, that's the route that should always be followed. But if the person can't consent due to lack of capacity, it would appear that for medical treatment of a physical disorder that's a manifestation of their mental disorder or a consequence of it, they could be treated either under the Adults with Incapacity Act or the Mental Health Act. And we would take the view that if there's resistance or objection to treatment for mental disorder or physical disorder that's a consequence of the mental disorder, it should be under the Mental Health Act. There are more safeguards under the Mental Health Act. If there's no objection or resistance, then you might proceed under the Adults with Incapacity Act because that would feel less restrictive. But again, the code of practice is quite clear. It's not necessary to detain an informal patient who can't consent, and that's for either treatment for mental disorder or physical disorder if the person is not objecting or resisting their treatment. But again, that can be a complex decision to make, and it's something that comes up frequently on our inquiries line, and we're always happy to provide advice and talk those situations through. The issue about determining the appropriate authority to treat to use isn't just a Scottish issue. There was a recent review of the Mental Health Act in England where the same issue came up, and the view in their report was in future only the Mental Capacity Act, which is their version of the Adults with Incapacity Act, should be used if a person lacks capacity but doesn't object. So their view was that you would use the least restrictive act, which was the Mental Capacity Act, but they did acknowledge that there were more safeguards under the Mental Health Act. And I suppose we find it's helpful when you're trying to decide which act to use to think about, is the patient detained? Do they meet the criteria for detention? If detaining a patient for the purpose of treating a physical manifestation of a mental disorder under the Mental Health Act should be undertaken with great caution. We would try to avoid detention under the Act unless it was absolutely necessary. But again, if there's evidence of them objecting or resisting treatment, then the Mental Health Act provides them with more safeguards. Does the proposed treatment fall within the definition of medical treatment under the Act? Is there a clear connection between the mental disorder and the treatment you're given? And will the treatment of the physical issue amount to treatment of the mental disorder? And if so, how? You also have to think about any advanced planning document by the patient. Is there an advanced statement? Is there some sort of advanced directive? The Code of Practice talks about treating chest infections that are causing delirium under the Act, or hypothyroidism, which is causing depression, can be treated under the Act. It also states that self-harming, including overdose as a result of mental disorder, can be treated under the Act. And it's quite clear about that. And it's worth considering that in the context of the case of 2009, a young woman who self-harmed through drinking antifreeze, and she was assessed as having capacity to refuse treatment. She needed dialysis for the impact of the antifreeze. She refused it. She was deemed to have capacity to refuse it, and she died. She also had an advanced directive in place, which refused treatment. And I suppose that clearly demonstrates that it can be very complex when you've got two sets of legislation, one very much focused on capacity and the other one on mental disorder, and the gap between those, and that can be, complex one, but certainly the Act is quite clear that you can treat the impact of an overdose under the Mental Health Act. And again, if there's no resistance from the person lacking capacity, the Adults with Incapacity Act would normally be the preferred route because it's less restrictive. But again, in these cases, we're more than happy to take phone calls and discuss things on the inquiries line. Things to consider when you're making decisions around how to proceed with treatment, what's the most appropriate legal authority to use. Does the person lack capacity to consent to the treatment or intervention? If they've got capacity, then it's simple. They consent or they don't. In law, there's a presumption of capacity, and the presence of mental illness or learning disability doesn't automatically mean that that's lacking. Also, disagreeing with the suggested line of treatment doesn't necessarily mean that somebody lacks capacity. People are allowed to make decisions that the majority may not agree with and that may be poor decisions, but if they have the capacity to understand the consequences of those decisions, they are able to make those. And there's a duty on the clinician to consider ways that the individual can be supported to make decisions, or at least make their wishes known about treatment. And we need to communicate in a way with the adult that they can understand. That might mean using simplified language, using pictorial information, involving speech and language therapists, but it is important that we make every effort to enable somebody to make decisions for themselves where they can be supported to make those. It's important to assess capacity in relation to the treatment decisions the person's facing, and we must be careful about presuming capacity unless there's a certificate that states otherwise. A presumption of capacity can be challenged if there's evidence to the contrary. And there's quite a lot of helpful guidance within the code of practice around how you assess capacity. Somebody needs to be able to understand in simple language what the treatment is, what its purpose and nature is, and why it's been proposed. They need to understand its benefits and risks and the alternatives, and understand in general terms what the consequences of not accepting treatment would be. And they need to be able to hold on to that information long enough to weigh it up and use it to arrive at a decision. So that's the issue about capacity. I'll talk a bit about benefit. Any intervention must be necessary and must be of benefit to the person, and that benefit must be expected to outweigh the potential harm. And sometimes that's really easy to establish. Somebody's having a heart attack, they need treatment, to preserve their life. In other cases, it can be much less clear. For example, somebody with a significant learning disability or dementia who's fairly confused and unable to really understand what's happening, has got bowel cancer. Now, an operation which would result in a stoma could prolong their life significantly, but the outcome of that and the subsequent management of that stoma may cause such a high level of distress on an ongoing basis that you would need to consider and weigh up whether the benefits really were of benefit to the individual, what the impact would be on the individual. And in those cases, you need to be consulting really widely with members of the care team, but also people that are involved with the adult, members of the family, proxy decision makers, but not just those, wider family members as well, quite often. And you have to consider that benefit in the widest meaning of the term and weigh up advantages and risks and harms, and that can be psychological harms as well as physical harms for the adult. We then think about the individual's views, their previous wishes. Advance decisions or advance directives don't have a formal status in Scotland under our Adults with Incapacity Act. However, if a clinician is presented with a competent advanced planning document which refuses an intervention, we would expect that would be regarded and respected. The principles of the Act talk about the duty to take into account past and present wishes, and we would say that a competently made advanced decision to refuse treatment should be taken into account and should be given weight in the clinician's decision, even though it's not legally binding. Now, advanced statements under the Mental Health Act are different. They have a different meaning. They are about treatment for mental disorder. They do not have a bearing on unrelated physical disorder. Proxy decision makers. If a person lacks capacity and there's a proxy, then again, as I've said before, their consent should be sought. We really have to involve them in the decisions. If the attorney or guardian refuses consent, then we've talked about dispute resolution under Part 50, that can go ahead. And because of the importance of involving proxies and getting their consent, it is essential that GPs, hospital wards, care homes ask when somebody comes in, have they got a proxy? Can they have a copy of the powers, and keep that on file and make sure that information is available to staff, because it's really important that you contact the proxies to get consent. And again, that's something we quite often see is not done as well as it should be. But it's getting better. People are getting more aware of it. Lawful and proportionate use of force. Force is always a last resort. You should use every other option for obtaining cooperation before using force. I think that goes without saying. Somebody's refusal and resistance might be based on just a lack of understanding. And even when somebody lacks capacity, if you give them well presented information, clear information, you might overcome some of that resistance. Also involving others, the family, the relatives, somebody they trust, to provide support, reassurance, might well negate the need to use force. Classic other one, somebody's got a fear of the dentist. If you've got time, there are psychological interventions, there's work that can be done to reduce those fears and allow the person to have treatment without having to resort to force. Mild sedation might also be considered as preferable to the use of force. And again, the use of restraint or other force is an interference with somebody's right to physical integrity. It's a big interference with somebody's basic rights and should only be used when there is a clear legal authority to do so. And it should always be the least restriction necessary, and it should be proportionate. We shouldn't be using a lot of force for a relatively small benefit. You've got to balance the effectiveness of the treatment and the necessity of the treatment with the need for force. It's not always a straightforward decision. It often requires quite lengthy multidisciplinary decisions to reach a consensus. So we would always expect that when somebody lacks consent, the primary practitioner would be having those discussions and would be certifying that incapacity. I'll just go over very briefly the legal options that we've talked about and covered. The legal options for providing treatment when somebody lacks capacity is, first of all, in an emergency situation, the common law principle of necessity, and that would allow conveying the person to hospital and immediate treatment, but only in an emergency when it is essential and urgent. After that, the use of reasonable immediate force under a Section 47 certificate, when the treatment is not an immediate emergency, but it's still urgent and there's no time to obtain authorisation, guardianship, intervention order. So if it's immediate force required to preserve life and prevent deterioration, then that can happen under a Section 47 certificate. However, if there's more time available, it would be more appropriate to go for guardianship or an intervention order to give that legal authority to use force. And there's also a duty on local authorities, if there are no relatives or family, to apply for a guardianship order or an intervention order. There's a duty on local authorities to pick that up and do so where it's needed. And again, administration of treatment under the Mental Health Act may be appropriate only when the physical disorder is a direct cause or a consequence of the mental disorder. So that's been a bit of a whistle-stop tour of our right to treat guidance, but hopefully people have found that useful and helpful.